all right? So let's look at the class 3 agents. So these are the drugs that exist to essentially prolong the action potential, all right? And these are, again, the potassium channel blockers. And these are the ones that are essentially characterized to increase the action potential. And you can you can physically see this by an increase in the QT interval, all right? And so these are really good for reentry circuits where there's a circus movement where instead of it going from point A to point B, now it goes from point A, point C, D, F, G, and then B. And so these reentry circuits or these circus movements can be molecularly targeted by using some of these potassium channel blockers. All right. So here's the membrane, the electrical gradient and the concentration gradient. And essentially what we're doing is we're moving kind of potassium out of the cell and we're moving sodium into the cell. And these gradients are the things that are kind of driving some of these faulty electrical pathways. And so what we're going to do is we're going to kind of slow things down or speed things up depending on which drug class we're going to talk about. And hopefully control some of these arrhythmias as they become manifested. All right. So as we transition now, so we're basically setting up the potassium-sodium current. And let's talk a little bit about the potassium channels themselves. You guys remember Dr. Shannon? Okay, of course.
So you guys remember probably this figure. This is our action potential, our ventricular action potential up top. These are our currents on the bottom. Remember, a downward deflection is an inward current. That means positive charge coming in. That means depolarization, right? More positive charge inside, membrane voltage goes up. So if you're sitting at rest, I have a myocyte, sister's over here, brother's over here. There's an action potential propagating down my sister. It hits the intercalated disc. It depolarizes my membrane. My sodium channel's open. I get a humongous increase in sodium, right? Sodium coming into the cell, and I get this huge depolarization really fast. And remember, the rate of that depolarization is dependent upon the rate of the influx of the positive ions. In the case of sodium, it's massive. This doesn't look very big here, and that's because unlike the rest of these currents, it's 1/50th of the normal size. If it was the normal size, it would go all the way down through the floor of the lecture hall, okay? So you've got that, that's phase 0. Phase 1 and 2, you have your potassium currents flowing, and that's what we're gonna talk about here, right? So your potassium currents are outward currents. That means positive charge leaving the cell. Potassium going from inside to outside. That means your potassium channels are trying to make your membrane voltage more negative. They're trying to bring it down back toward rest. And during phase 2, in particular, the plateau phase, that's opposed by positive influx through the sodium-calcium exchanger, 3 sodiums in, 1 calcium out, and through the calcium channel. And we're going to talk about calcium channel blockers a little bit later. The calcium channel is trying to keep you depolarized. So you've got a tug of war going on. And eventually the potassium channels win, primarily your IKS, which is a delayed rectifier. That brings you into phase 3, and that brings you back down to rest where your inward rectifier is most active, okay? So that was a really quick way to go through what was an entire lecture last year. So we're going to talk about the potassium channel blockers, and again, those are outward currents, and we're talking about them being active mostly during the plateau. So you guys remember from last year, if you decrease the potassium current, let's say, for instance, we had long QT syndrome 1, where there was a mutation in the slow potassium delayed rectifier, IKS, and that resulted in a longer plateau phase because it took longer for the delayed rectifiers to finally overwhelm the calcium current in the sodium-calcium exchanger. And it extended that plateau phase, okay? And what that means in terms of what Dr. Broderick was just talking about, it extends your refractory period, which means it extends the period of time that you have before another action potential can depolarize that membrane. And in the case of arrhythmias, that's frequently the cause of the arrhythmia. You're getting a depolarization when you shouldn't get it. So you keep the membrane more refractory longer, it can't be depolarized during that time, So let's take a look. This is a big diagram for me because it explains an awful lot. So ordinarily, you have your action potentials. They're propagating down along whatever pathway we're talking about in the ventricle. You guys know it spreads out. And in here, this little triangle, that's not excitable tissue. Could be just a lot of collagenous tissue or, you know, some other sort of insulating tissue that really isn't excitable. It could be a site where you have a myocardial infarction where, you know, you cut down on the oxygen, the tissue's not as excitable and it doesn't travel through. So that could be extremely bad. Because what happens is, this is normal as well, you get this depolarization, and what it does is it just goes around the point where you're not getting a propagation. And it goes around, and you guys can see it spreads out along another distal pathway. And these two waves, they separate at X, but they come together right here, and they basically just annihilate each other. So nothing bad happens. They just go around and come together, and they hit each other, and that's it. All the tissue's depolarized, okay? And meanwhile, you've got continued propagation out here and here, okay? Not a big deal. That's how normal tissue works. Well, if you get an area of ischemia in what would normally be conducting tissue, this alpha and beta pathway, they don't conduct action potentials at the same rate. You get what's called a unidirectional block. And what that means is that the action potential splits at X, but it can't go down this beta pathway. It only goes down the alpha. So now it comes back around, comes up through here through this distal pathway, and then back up the beta in the wrong direction, okay? And it doesn't really want to travel up that beta pathway all that quickly if it's damaged tissue, but it still does it, okay? And how slow that propagation is a big deal. If it's slow enough, then what happens is that that wave comes around and, or if it's fast enough, that wave comes around and it hits this alpha pathway again while the alpha pathway is still depolarized. And that means while it's still refractory and it can't be re-stimulated. So in that case, your wave just stops, okay? It's annihilated just like it was before, no big deal, no harm done. But if it's slow, and the worse this damage is, the slower it is, then what happens is you come back around and you hit this alpha pathway after it's recovered. And if you hit it after it's recovered, you re-excite it. And you re-excite it, and the wave goes down the alpha, back around, up the pathway, re-excites the alpha again, comes around, up the pathway. What you've got is an arrhythmia. You've got a bunch of depolarization going on in these branches that shouldn't be there. Those waves should have annihilated and just stopped, and then you should have allowed repolarization. Well, repolarization can't take place as long as you've got this wave of depolarization going around and around, okay? So this is called a reentrant pathway. So if you look at this, you can see how a potassium channel blocker, a class 3 antiarrhythmic, might really help. Because what's happening is you increase the refractory period in this alpha branch. And so even though the propagation back up this beta branch might be slow, if you can keep the alpha depolarized for long enough, it'll come back around and it'll hit this alpha branch while it's still depolarized. So you're lengthening that refractory period. You're lengthening the amount of time that can go by before it repolarizes and can be re-excited. And so even though this beta pathway is slow, maybe you can keep this alpha pathway depolarized long enough to where it'll stop the depolarization and prevent a reentrant pathway, okay? That's basically, in theory, how these work, okay? So what you're doing here is you're lengthening the action potential, you're increasing the refractory period, and you're decreasing reentry, okay, in theory, all right? Back to you, sir.
Thanks.
And just a quick point there. I think that's like the key diagram right there, that whole reentry circuit. So as clinicians and as cardiologists, when they're looking at the arrhythmias that are present, majority of the arrhythmias, whether they're ventricular tachycardias or supraventricular tachycardias, if you're asked what their mechanisms are, the predominant mechanism is reentry. It's a reentrant arrhythmia. There are some other minor mechanisms that you guys and so forth, but this is probably the main reason why. And where this reentry circuit is determines that you see. So if you have a diseased ventricular tissue and you put the reentry circuit in the ventricular tissue, remember what's the intrinsic ventricular rate in that 25-30 range? You put a reentry circuit there, that's that V-tach that you saw. You put it in the AV node, you have AV nodal reentrant tachycardia. You put this all over the atrial tissue, you have atrial fibrillation. So that's the concept. So tying it, I mean, this is sort of going from sort of like the base to clinically what do we see. So majority of arrhythmias that we do see, there's a few other mechanisms, and this is probably the hallmark way of explaining this. I always have a tough time explaining this to students, so I will be referring everybody to this PowerPoint, this slide, this page, this.
Thanks, Dr. Shaw. So what are these potassium channel blockers? So mechanistically, they all pretty much have the same mechanism. So we're going to block this potassium channel in the cardiac muscle. And these drugs are listed here: amiodarone, dronedarone, abutolide, dofetilide, and sotalol. Okay? And probably the most clinically relevant, the most important drug in this group is number one, amiodarone. It's the most potent out of all of them, okay? And it has a lot of uses for a whole bunch of different cardiac pathologies. The problem is that it's so potent, it also has a lot of side effects, okay? And so it's kind of a double-edged sword between treatment and therapy, but let's kind of examine a little bit more of these. So amiodarone is actually structurally similar to the thyroid hormone. So you can imagine what some of the side effects would look like. And those are linked to basically interactions with the nuclear receptors that are associated with the thyroid hormone receptor. Amiodarone itself is lipophilic, and it goes to fatty tissue. All right, and this is kind of a difficult in terms of pharmacokinetics because it'll go into the tissue relatively slowly over the course of several doses, but it also leaves slowly. So that's kind of a problem. So if you think of an overweight or obese patient and the fact that they have amiodarone on board, there can still be some of this drug persisting well after the last dose has been given. In terms of oral administration, it's great. It'll restore the SA rhythm to patients that have atrial fibrillation. If you give it IV, it can actually terminate ventricular fibrillation or ventricular tachycardia relatively quickly. Okay, so what's the difference between those two? Patients can live with AFib, for hours, days, weeks. How long can you live with VFib? Was it 3 minutes? 2 minutes, if that, before they go into full cardiac arrest? Okay, hence the oral administration of amiodarone for rhythm control, and then IV administration of amiodarone for acute termination of VFib, because you only have a few minutes. And so, as we said, amiodarone can be given orally or IV, and mechanistically, it's going to prolong that action potential that Dr. Shannon talked about, and the QT interval by blockade of this specific potassium channel. Even though it's described as a class 3, and this is where this gets really tricky. So the Vaughan Williams was basically made to make learning antiarrhythmics easier. I think it actually made them harder. Even though amiodarone is a class 3, it will also block sodium channels. It will also block beta receptors, although weakly. And it will also block calcium channels, albeit weakly. Okay, so even though it technically is a quote-unquote potassium channel blocker, it has principal outcomes in the other 3 categories, which makes it, in terms of the Vaughan Williams, kind of annoying. So what will happen physically if you give a patient amiodarone? It's going to slow both heart rate, okay, but it'll also slow the AV nodal conduction velocity or the frequency. You will get some peripheral vasodilation if you give it IV. Maybe it's the solvents. Can't really explain it at this point. With patients that have pre-existing sinus or AV node disease, specifically bradycardia, and heart block, this might occur. So you might get some of these side effects coming up in certain other anomalies. As you said, amiodarone can accumulate in many tissues. There's a dose-dependent pulmonary toxicity. There's deposition in both skin and eyes, and so with the skin, you can have some photosensitivity, especially if you give it in the summertime or in a warm area. This wouldn't probably be an issue in November in Chicago, because it's usually dark for the whole month. Eyes, you can see corneal deposits, and then there can be visual disturbances as well. And then, of course, there is a thyroid hormone side effect as well. In the periphery, it can actually block the conversion of T4 to T3. So patients that are on kind of long-term amiodarone therapy, you would expect to see disturbances in their thyroid hormone levels. It has variable bioavailability, hepatically metabolized, of course. And the half-life complex is a little odd because you said it, spends a lot of time in fat tissue. So the one component can be anywhere from 3 to 10 days. The other component, the other metabolite, could be several weeks. So this thing will be sitting around for quite some time. It's a substrate for CYP3A4, so there's lots of drug-drug interactions. And the effects of this drug may persist for several months, depending on the patient's physiology and so forth, because it could be hiding in their fat. Bless you. Dronedarone, which is a derivative of amiodarone, the exact mechanism of action is unknown. It shares properties of all 4 drugs within that category, and it's structurally similar to amiodarone. It was kind of the precursor molecule. This will block sodium channels. It'll block beta-1 receptors. It'll alter adenyl cyclase activity, so it's a negative inotrope. It'll block the potassium in a specific channel, and it'll eventually prolong cardiac repolarization. And like its cousin or sister, amiodarone has CYP3A4, or dronedarone has CYP3A4 metabolism. Okay, and basically with dronedarone, you can see kind of the use of this in kind of paroxysmal or persistent atrial flutter. And it's been shown to reduce hospitalization in patients that have sinus rhythm problems. Right. Other drugs within that class 3 category include beryllium, which is listed here. It was first used as an antihypertensive agent a while ago because it actually interferes with the release of catecholamine. So this is actually much more earlier than the receptor. This is the actual noradrenergic neuron secreting norepinephrine and epinephrine and so forth. So beryllium actually interferes with the release of any of these catecholamines. When you give it systemically, it'll lengthen the ventricular but not the atrial action potential. And it has kind of an effect on those ischemic cells. And so depending on like the length of the infarct or the amount of the infarct, you can kind of see that there could be dramatic changes in how a patient will respond to that. What's interesting about this drug is that when you give it, it first causes a surge of catecholamines when it's first given. So it actually, the first dose is a positive inotrope. And so when it's used by itself, it can precipitate arrhythmias. And so guess where this falls on the ladder in terms of your first go-to drug? It's way in the back shelf. Okay, so it exists. It's clinically relevant for specific diseases, but it is in no way your first pick. Okay. My major side effects, of course, as you would expect, postural hypertension, hypotension. Sorry, and of course you would treat that with your co-administration of a central agent, which we haven't talked about, such as a tricyclic antidepressant, protriptyline. Okay, so where do you use beryllium? Crisis situations after lidocaine and cardioversion have failed. So there's other drugs that are kind of your first or second choice drugs. Beryllium would physically be number 3. Okay, so it exists. It's out there. We talked about it. We're done. Okay. The fourth drug, or the last drug on that list, was sotalol. So based on its name, what do you think it is? Sotalol. Right? Of course, it has some beta blocking effects. And so actually this drug was discovered as a beta blocker, and it is. Only the left-handed version is the beta blocker. The D version, or the D isomer, has the action potential effects. And so that's really why it's kind of both a beta blocker and a class 3 anti-arrhythmic. So this is one that has kind of shared activity. Oral absorption is great. Half-life is about 12 hours. So you can still see it used clinically. The final group would be the final potassium blocker would be dofetilide, and this one is the one that blocks those delayed rectifier potassium channels. It'll cause hypokalemia. real slow rate of recovery after blockade exists. And so it's okay to use. It'll maintain normal sinus rhythm in patients that have AFib, and it'll prolong that QT based on plasma concentration. So you can directly correlate the side effect with how much drug was given, which makes this drug relatively useful in terms of its clinical management, because you can actually kind of guesstimate where that QT prolonging effect is going to occur based on the patient's plasma concentration. So that's relatively a useful drug. I still say dofetilide is probably maybe second on the list after amiodarone. Ibutilide is another one that'll kind of be used clinically. It'll block that slow inward sodium current through another mechanism. And this drug is really good at kind of converting atrial flutter and atrial fibrillation into normal sinus rhythm. But the adverse effect, of course, would be a QT elongation. Metabolically, it's secreted by the kidney, so if there's any dramatic renal health consequences, you may want to maybe avoid this drug. And it's also cleared hepatically as well, so there's both a real potent clearance of both liver and kidney on this particular drug. And so this kind of basically just summarizes the clinical pharmacology of the class 3 agents. Okay, GI absorption, elimination, half-life, and the dosage range. Of course, for this particular lecture series, you don't have to worry about the dosage. We're not there. We're not there yet. Okay. This one, sorry, it looked better on the other slide, but this is looking at the electrophysiologic properties of these class 3 agents, comparing amiodarone, sotalol, ibutilide, and dofetilide. Okay, and we can go through some of this as we go through. We'll go through the whole lecture series, but essentially what we're looking at is, efficacy, outcomes, and the ability to treat some of these different conditions.